you cannot get hired at a Whole Foods unless your team says you should be part of that team. Now, to my mind, the teamwork that happens at Whole Foods is a lot less important than the teamwork that happens in our environment. So why are we not looking at some of these interesting hiring practices or firing practices, right? We work with Golden Valley Healthcare, which is a safety net clinic, and they're trialing a $1,500 voluntary resignation program that was stolen from Zappos. So if you apply for a job at Zappos, at the end of the application period, they will give you $3,000 to not take the job. Because if you'd rather have $3,000, you're not the right person for their environment. Right? So Golden Valley is doing that same thing. They've got some people that are just not great team players, but it's a tough economy. You can't just stop working. So here's an opportunity for you to take this and find your feet elsewhere. You don't belong in our organization. Other things that cause burnout. The death by 1,000 paper cuts. Yeah, death by 1,000 paper cuts. And that's the tool that I'm going to show you at the end and walk through is precisely to address that death by 1,000 paper cuts. And it won't hit all of them. But sometimes if you can knock them down to 500 or 400, they become more manageable. So there's a great study that was done looking at empathy scores of physicians from med school through the beginning of practice to nearing retirement. The curve is rather discouraging. Most of us are probably in this practicing phase, some potentially nearing retirement. We certainly work with people at the beginning who are going through that plummet. This, by the way, is the exact same curve that happens in marriage. This part is called children. But, so there's, and our goal is to flatten that curve. So looking at some of the systemic barriers, you mentioned earlier the EMR. This is a picture that was submitted, I can't remember which journal, but it was published in one of the journals, given to a physician by his child patient. And I know it's a little hard to make out, but here's the patient, here's her mom, her sister's playing over there in the doll, here's the doctor at the computer, facing away, playing with the EMR. So technology can be a part of the problem. It doesn't have to be. I think as we get more experienced designers in the creation of technology, or let's get physicians involved and nurses involved in the creation of some of these technologies, some of that starts to go away. We also get mandates from the outside, what we like to call meaningless use, right? These are actual pictures given to us by a surgeon of a 20-day stay circa 2001 from a paper chart and a 14-day stay circa 2011 from an EMR, printed out from an EMR. Right? EMRs were, and I'm not going to stand here and say technology is a problem or that physicians or nurses don't like technology. Before I joined Vocera, I spent 15 years in market research looking at technology adoption and healthcare and behavioral science. And physicians are among the first adopters of technology. How many people in this room have a smartphone? How many people have a tablet? How many people have multiple computers at home? Yeah, we don't hate technology. We hate technology that takes somebody else's job and puts it on our plate, or asks us to be billers instead of medical professionals. Right, so we look at, and to some extent, some of those are things you can't control, but some of those are things you can look at and say, how can we tweak the system to help solve that problem? Because ultimately the problem is exhaustion. There aren't enough hours in the day to spend the meaningful time with patients to meet all the requirements. And there are, I think the core concept is one that anyone who treats alcoholic patients will be familiar with. Everybody ready to do this with me? God, grant me the serenity to accept the things I cannot change, the strength to change the things I can, and the wisdom to know the difference. We're not going to solve the meaningless use problem, right? But you can control your reaction and your response, and to some extent the specifics of your practice around some of those things. So I'm going to talk about some solutions on a couple of different levels. One is your individual level, right? You may also have heard this, everybody's mom loves to say this. You can't control people, but you can control how you respond to them. Right? We were talking about control during lunch. And you're certainly not in control of the system, although I'm glad that the Medical Society of Virginia is helping to push the system in ways that are good for you. But you are in control of your reactions and your responses. And so there are things you can do on an individual level. The more you connect to purpose, the more you find, reconnect to passion, that moment of passion with the patient. What's your passion? Sharing your passion with colleagues. That also helps make the work more doable, right? When the goal is something you really want to do, the work is not work. You were saying earlier, you love your job, it's not work, except when you have to work with some annoying people, and then it is work, right? There's also sharing responsibility, right? And I was very happy. Am I messing this up, Dr. Epstein? Is that who it is in the back? Epps, I apologize. Dr. Epps was talking about some of the shifting that they did in scheduling and some of the sharing of responsibilities so the nurse practitioner or a nurse is doing some of the work that a physician doesn't have to do. That's actually part of the solution as well. As we move to team-based care, physicians have a tendency to think, well, most of us have a tendency to think nobody can do it as well as I can do it, right? And we're our own worst enemies in that regard. So the more we can think about how can I build a team of people that I trust to where they can be doing some of the work that today is making me crazy. Or where can I invest differently to have potentially some different roles in my practice in order to make that possible. And then finally you can't fix the system as an individual, but you can control your local environment and engage people in a way that is problem solving and creating that kind of engagement. I'll talk about that. That's probably the most abstract. But let's start at the individual level. Who's heard of the Dalai Lama? Right? The concept of mindfulness, the concept of being present and being aware is not a new concept. It's been around for ages. It's often considered soft and kind of froofy, right? If I sat up here and I could walk you through a breathing exercise, I think I need a breathing exercise. I'm having a little trouble breathing up here. But most people would roll their eyes, right? Particularly get a group of doctors, get a group of surgeons, get a group of orthopods to engage in mindfulness. It's pretty difficult to do, but it's actually extremely effective. So this is a study from JAMA. Now, granted, this was voluntary, so there's some selection bias. This was offered to all primary care physicians in a district in New York to put them through a fairly intensive training that involves some didactic learning, some mindfulness meditation, some narrative exercises, some discussion with their peers. And it went over like a 6-week period. And they tested them at 30 days, at 120 days, and at 180, or not 180, 18 months. And they tested them on these validated scales for burnout, empathy, mindfulness, total mood disturbance. The study is free for anyone who wants to download it, and I'm happy to provide the link. But there was improvement across all of these from this mindfulness, from this approach. Now, most of you are probably saying, I do not have 6 weeks to put into some sort of intensive training, and I don't blame you. One of the things that we do in the Experience Innovation Network is say, okay, where are there proven constructs and how can we make them more accessible? So we were approached by San Mateo Medical Center to do exactly that, to put together a much more accessible mindfulness kind of program. And the first thing we thought is, well, the heck do we know about this? So we found a physician who was an expert in mindfulness and partnered with him to lead it. And we created a program that was relatively simple. It did involve 2 in-person sessions. The first one was about 2.5 hours long, and most of it was spent convincing people to give mindfulness a chance. Right? To not roll your eyes and not turn away. There was some homework. So people were given a recording that Dr. Dinenberg created. It was like a 2 or 3 minute guided meditation, 2 or 3 minutes so that they could slip it in between seeing patients. So they could do it easily, just sitting in the car in the parking lot before they come to work or after. They were given gratitude journaling as to just write down one or 2 things every day that they're grateful for. Has anyone read the book 365 Days of Thank You? I would recommend that to everyone. This guy did a project to write a thank you note, one thank you note every day, turned his entire life around. And I'm not promising that for everybody, but gratitude is incredibly powerful. And then we had a second session to come back and learn some additional skills and to share some of that and to learn some more meditation. And what we saw was that 90% of the program participants saw a reduction in their burnout. So we tested the burnout, we tested the empathy, we used, those scales are readily available. And we saw people saying things like, I feel like I'm awakening, I can see for the first time. We heard a lot of thank you, this is helping me relax a bit. We heard people talking about, one of the meditation pieces was to find your tree, to go, visualize yourself sitting under a tree quietly, and people would start referring to their tree, right? I need a second, I gotta go find my tree, From a different study, and this is one of my favorite stories, just to show how simple this can be. This was a different program we were doing with another organization, with physicians. So we asked them to create a ritual or routine, right? We have all kinds of rituals in our lives. Most of them are not geared towards mindfulness, but you can create one. So this guy decided on his drive home every day, he drove past this pond. Usually whizzed right by the pond without paying any attention. But it's a pretty place. So he decided he would stop each day and just spend a couple minutes and visualize dumping the stress and worries from the day into this pond so the pond could contain it and wash it away. And then he would get back in his car and drive the rest of the way home. So he's doing this for a couple of weeks, and his wife sits him down and says, honey, what's wrong? Are you having an affair? You are being far too nice to me. He had reduced his stress and that sense of bringing his anxiety home with him so significantly that his wife, who is the best measure of these things, our spouses often, saw the difference. So it doesn't have to be, when I'm saying mindfulness, when I'm saying gratitude, it doesn't have to be some massive, completely interrupt your day kind of thing. In fact, one of the things that I've done with a friend of mine, and I have no data that shows this works, but I can say anecdotally is great, I text her every day, and she texts me, one thing we're grateful for. By being accountable to each other, we're more likely to do it. By seeing her gratitude, mine is amplified. So Twitter is another place that can happen. I just found this earlier this week, but look at this. 256,000 followers of simple gratitude tweets. So I want to pause for a minute and ask if there's anyone in the room who has experience with mindfulness or gratitude or other or rituals or routines, and ask if anyone would share any ideas. Yes? Everything counts.
I tried to bring yoga to the office for staff.
Mm-hmm.
And I found a yoga instructor that does yoga for patients. So I bring coffee. And so the yoga instructor volunteered to come. It was $5 per staff member per class. And we tried it for 3 months. She needed 8 people to participate. We have about 35 staff members. I had 6 people that participated. So we did it for 3 months. She lives far enough away that we were just trying to cover her gas money
Mm-hmm.
from the office. We did it for 3 months and it stopped. But
But you tried it.
we tried. And the people who participated loved it, so we may try again.
And some of them may have gone out and found other yoga opportunities. So yeah, no, they didn't. No, but that speaks. That speaks to a couple of things. One is sometimes you have to just make it as accessible as you can. 2, you're not going to get everybody, and not everybody's going to resonate with the same approach. Yoga is a very physical approach to mindfulness and meditation. Some people aren't going to like that. Some people aren't going to want to do that with their coworkers, right? But the point is to try it and to tap into local resources. You will find yoga instructors are like physicians, very mission-driven. And so they will often make their services available at cost or below cost. Any other attempts, failed or otherwise? Yes?
A few years ago, our office staff was a lot different. We had a lot of between the front office staff and the clinical staff, and I'm the only male in the office. So there
I'm sorry.
18 ladies in my office and me. And I really didn't want to walk into the office because I knew the tension level as soon as I walked through the door on the way up. So I went and took a Tai Chi course. And,
Mm-hmm.
And in order to do the form, you had to really concentrate on what you were doing, because if you did the little Chinese gentleman would yell at you. So to avoid the wrath of the instructor, you have to concentrate, but it doesn't allow you to think about other things. I found it was a sort of 6th grade before. I found it very beneficial in the relief.
Absolutely. Yeah, for me it's rowing. I was a swimmer my whole life. Swimming makes me crazy, but rowing I still have to focus on that balance so much that it takes me out of everything else. So the point is that there are things you can do on all different kinds of scales. Things that are individual to you, things that you pair up with a partner, or things that you do in a group that allow you to step back, regroup, and put things in perspective. As healthcare professionals, we do deal with life and death a lot. But it's helpful to step back and realize that some of the administrative stuff that's put on us is absolutely not life or death and needs to be put into that perspective and can be streamlined, right? We're so used to dealing with life and death at that life and death level of anxiety that we often will put it on everything else that we do. So stepping back, giving yourself a moment to recognize that patient that you connected with, that one connection you made that day, and really value that will have a huge difference. So it's also possible to create system-wide kind of solutions that reinforce this. And so this is a concept that was created at a hospital in Hawaii by by Earl Bakken, who was the founder of Medtronic, who created this sort of perfect hospital environment. And this is a concept called code lavender. Everyone's familiar with code blue, right? Somebody's physical heart needs immediate resuscitation. Well, when a code lavender is called, it's called because somebody's emotions need immediate resuscitation. And code lavender was originally created for patients, right? Patients have emotional crises in our environment all the time, particularly in some of the more acute care environments. But staff are living in that environment as well. And so, if the kinds of things that happen every day in a hospital happened at GE or happened, at any other kind of company, they were calling crisis counselors, right? And we're just expected to go on to the next patient. So code lavender is basically rounding up a team of people, and often they are the people that are already there. We heard about palliative care earlier, right? Those palliative care resources, pastoral resources, alternative healing resources, sometimes external partners in the environment who do meditation or Reiki or yoga or those other things. Sometimes, frankly, it's cookies, right? And so the idea with the code lavender is that whether it's physicians, nurses, or patients, that when a code lavender is called, this rapid response team steps in with whatever resources the organization has decided to make available. So we did an implementation of this with Lucille Packard at Stanford, which is a pediatric hospital in their PICU. And we did it specifically for staff, so not for the patients and families. And we tested out a number of different factors. We looked at burnout, we looked at some of those empathies, but we also asked people, how frequently do you feel supported by anyone in the organization? And originally there were 24% of the staff who said no one. Now imagine that. 1 in 4 people essentially feel that nobody in the organization is there to support them. By the end of the Code Lavender implementation, and this is not an expensive thing to do, it's not resource intensive. Often, again, it's the resources you have, but by the end of the Code Lavender, they dropped that down to only 2.7%. When we went in and we never go in and do any program, and I wouldn't recommend anyone doing anything like this without first stepping in and talking to the staff about what are your needs, what are the problems, does this solve a problem that would be useful to you? And a woman came up in tears at the end of that session and said, I worked here for 35 years and nobody's ever acknowledged that this work is hard and that I have emotional needs as well. So these kinds of putting in place these more system-wide solutions or ways to support each other are other powerful ways, and there are inexpensive ways to do that as well. And then these are some examples that I pulled from the In Search of Joy in Practice article that we distributed, which are about sharing the work, right? About looking at ways that you can organize practices within your practice so that it is more rewarding. So for example, putting pre-visit planning and completing labs before the visit means that instead of the doctor spending her time deciding these labs need to be ordered, which they probably knew based on the patient's medical history, they can actually have that connected discussion with the patient about what to do about the results. Right? It's completely backward to have a patient come in face-to-face, decide you need to order these 6 labs, unless it's an emergent situation or a new situation, and then have the discussion of those results happen by a postcard, right? Which is often how we do it, right? It makes much more sense to say, based on those symptoms, here's the labs we need. Now let's have the discussion about what you need to do in person. That's much more engaging. The idea of stable medications renewed at an annual medical visit. A lot of calls into practices are about, I need this renewed, I need this refilled, I need this shifted. So, and this is something my own, I belong to a Harvard Vanguard medical practice in Boston. This is something they do every time. These are your maintenance meds. Are you still taking these? Are you having any problems with them? Let's get them renewed so that they don't have to deal with those phone calls and the staff can deal with other kinds of phone calls. Those phone calls might be to get chronic patients in for scheduling. Those phone calls might be, we have a clinic again in California that's using extras, and I say extra, but staff time that was freed up from busy work like responding to those refill calls, that's now having those same staff call out to patients in their patient-centered medical home program who have set a goal, just to say after 6 weeks, how's that going? Imagine the difference somebody feels, or that call center staff person feels about their job when it's not, yes, I can renew yet another medication, but it's actually helping that patient to work towards their goals. And then on the EMR front, MAs or sometimes nurses acting as medical scribes. I think scribes are a concept that don't get nearly enough attention. And they don't work in every situation, and they don't work for every patient. But there's no reason a healthcare professional needs to be necessarily the person documenting, particularly not documenting for the billing purposes, which is what most of what an EMR does, but even documenting some large elements of the clinical encounter. There's a company that we bumped into created by an ER doc called ScribeStat, and there are multiple companies and multiple studies. But ScribeStat does a model that I really like, which is that they partner with local medical schools and find aspiring med students who want to take a gap year and have those students act as scribes. So you've got highly motivated people who want to be in the clinical environment, who are young enough and inexperienced enough that you don't have to pay them a fortune. Not that we should be nickel and diming everybody to death, but it matters what the scribe costs. And there have been studies in different clinics that'll show dramatic increases in productivity for clinicians by using scribes, which then ultimately pays for the cost of the scribe. I've also had physicians come up to me and say, I would be willing to split the cost of this scribe with the system for the peace of mind and quality of life that it gives me, right? But nobody's ever asked me that. So thinking about, if this is the part of the work that drives me crazy, and you certainly don't need an RN or an MD to do this part of the work, can we think creatively about getting others to do the work? And in this Restoring Joy to Practice article, all of these organizations have thought creatively about how to redistribute the work such that it's more effective. In some of these cases, you need to also look at how does communication happen in order to make sure if you're splitting work, the care is still cohesive, but there are approaches for that as well. And so I want to share one more story here that's sort of a systemic kind of thing, and it's going to lead into the exercise that we're going to do. So we worked with a rural hospital in Missouri called Twin Rivers Regional Medical System. They were the lowest performing system in the HMA system, or the lowest performing hospital. And we worked with their med-surg floor, the lowest performing floor, which is not where I would generally recommend doing change elements. But this case happened to work really well. And we went in and they had a lot of morale issues and a lot of challenges. And being a med-surg floor, they often got people who had been through the ED, which is generally not a great experience anyway. So people were coming to them grumpy. and then they were reacting with their defensiveness. So they created this program that they call the Sacred Moment at Admission. Sacred not because it necessarily has a religious component, but because it is sacred. It cannot be violated. It must be delivered. And the idea is that when a patient arrives on this med-surg floor, what do we normally do when somebody arrives for admission? Do you have insurance? Yeah, well, living will, right? So can you pay, and if you die, is not the greatest way to start off a relationship. So instead, they started with sitting down and saying, what are your fears and concerns? Which oftentimes is, who's going to feed my cat? And I don't care what else you say about my medical care, I can't hear it until I know somebody's taking care of my cat or my sister or my wife or what have you. It's also, you've just been through the ED. Have you had anything to eat? Can we get you something to eat? Are you generally warm or cold? Do you need a blanket? Do you have any spiritual needs that we might have resources to support? Because often there are resources in the hospital. We wait for the patient to say, I need, and they instead sat forward and said, we have. And what they've seen over the course of this, and there were some other changes, and I'll talk about them more in depth a little bit later, was a 117% increase in patient satisfaction, but probably as important, physician satisfaction that went from being in the toilet to 95th percentile. And they got the Guardian of Excellence Award from Press Ganey for that. And we've heard stories from physicians, stories from nurses. They sort of rotate who does the sacred moment on admission. A great story from a nurse who said, I was tired. I got called to do a sacred moment, walked into the patient's office, pulled my smile out of my pocket, stuck it on, and then sat down and asked this person what they needed, and they asked for an ice chip. And it suddenly hit me how vulnerable you must be when your needs are down to, please, I can't even get it for myself, can somebody get me an ice chip? And she said, my smile, I remembered why I got into care in the first place, which was to care for people. My smile never went back in my pocket that day. Right? That reconnecting to the people is really powerful. So I want to pause for a minute and ask if there are questions, because I'm about to get into making you guys do some breakout stuff. Yes?
Not necessarily a question, but I'm actually on the board of a free clinic locally, and one of the things that struck me that you're really highlighting here is they actually have a program that gets used for people's pets because they were finding it something in pet development. They were finding that people wouldn't, they would give the food to their dog or they would do other stuff. And so that was a program, understanding that was a barrier in their medication adherence and their ability to function.
Mm-hmm.
By solving that, they were able to really exponentially affect their personal.
Yeah, absolutely. We have core basic needs, and our emotional needs sometimes trump our physical needs in odd ways. And so being able to, and particularly if our emotional needs are unmet, our ability to learn is substantially diminished. So we were talking earlier, a lot of the innovations were around communication and education. Those can't happen in somebody who is completely emotionally blocked off. And frankly, in almost every medical situation, there's some amount of heightened emotional anxiety. Yeah?
I'd like to ask for some help understanding one of the suggestions you made as far as maybe a scribe. The cost of a scribe would allow the doctor to see more patients and make more money to pay for the scribe.
Mm-hmm.
Which sounds like a good idea to me, but I've been promised so many times over the years, if only I would do this, for example, join an HMO, then
Yeah.
I can see more patients at less money per patient. But then I can, if only I would do this, if only I would pay this, then I could do more.
Right.
Make up for it.
And I don't think that's what this is. I don't think that's what this is proposing. A scribe, yeah, a scribe would not be, the purpose of a scribe is not to squeeze more patients into your day. It is to take the time that you currently can't devote to patients and have to devote to typing or the time that you're not spending face-to-face, which is diminishing potentially the quality of your care and certainly the quality of your life, and shifting that to someone else at a certain financial cost. Not everybody is going to recoup those costs. It's going to depend on your practice. It's going to depend how efficient you are working with the scribe. It's going to depend a little bit on what that scribe costs. It's going to depend on your market. I can show you some studies, and they're not studies we've done, but some studies that show some of the variability in some of that. And they're not a panacea. And so sometimes you will be slightly net negative on the revenue. Sometimes you will be slightly net positive. But the question is, what else have you put into balance in terms of the quality of your practice, the quality of your life? Some physicians will choose not to make up that revenue, but to invest that money in going home an hour or two earlier to be with their families or to pursue a hobby or something else, right? So it's a question of what you would like to offset by using that scribe. And it may be that it's not going to be, some people are super efficient at using their EMR, and it's not going to be the right answer, or they like using their EMR, or frankly, there are some organizations who simply will not allow you to consider scribes. But in most cases, the discussion hasn't been had, and that's what I'm encouraging, is for the discussion to be had if that's one of your major barriers. You're welcome. Okay, so now we're going to shift into some tools that are about taking control of your local environment. And your local environment may be as small or, in some cases, as broad as you want to consider it. And I told you about the Twin Rivers story, and I want to delve into it with the sacred moment. I want to delve into it a little bit more deeply about how it came about. So these are the three amigos. It's in the middle, Dr. Steve Pooh. He is a general surgeon. On the left, you've got Dr. Landry, who's an orthopod. And on the right is Dr. Perez, who's an OBGYN. These are the three physicians who looked at that med-surg unit within the Twin Rivers Regional Medical Center Hospital and said, we're drowning. We can't keep doing this. And Dr. Pooh was the medical director. So there was some buy-in and ownership in the higher levels of the organization, but most importantly, there was leadership from local trusted physicians. I think local trusted nurses can also get a lot done, although the hierarchies in hospital make it harder for nurses to be some of those leaders. We actually advocate for a triad leadership model: leader physician, leader nurse, leader administrator, for doing a lot of these changes. And so the first thing that they did is have this town hall communication series. Give people, they walked in with the assumption that things suck here, but they don't suck because people want them to suck. Right? Is that a fair assumption in most of your environments? Right? Something is going on, something has gotten under people's skin. Let's have it out. Let's create a safe environment where people can bitch and moan, and then shift them towards how we can solve some of these pieces. They also did some culture and team building events. One of the disconnects was a disconnect between physicians and nurses in this lack of sort of team orientation. So the physicians would sponsor bowling. They rented out this local bowling alley, and one physician would take each hour and sponsor that for their nurses to come in. Connecting with people on a social level can be really powerful. They also started doing handwritten thank you notes to thank each other for the work and the support that they did. And this is a story not from Twin Rivers, but from an OB-GYN practice in Albuquerque, New Mexico, but it made a big impact. I heard a physician once say, I don't talk about physician extenders when I talk about my certified nurse midwives. They are not physician extenders, they are colleagues. And they play an important role in the care of patients, and we work together, and each of us is responsible for those positive outcomes. So I think that idea of the thank you notes, the culture and team building events was part of that sort of bringing it together to recognize that neither of our work is as powerful on its own as it is when it's put together. Another piece of the solution that they created, and I would encourage, frankly, if there's one innovation that you take away, this is the one. They created what they called the No Excuses team. Now, the No Excuses team doesn't happen in a vacuum. It happened in the context of that, let's have some broader discussions, let's collect information and hear from people about what's not working well. But the No Excuses team was geared towards that solution of the death by 1,000 paper cuts. Let's recognize that so much just gets, these little things just beat on us all the time. So it was, and the task of the No Excuses team is frankly to channel your inner 5-year-old. Why? Why? Right? So, for example, they had a problem with charting not happening quickly enough, so the orders weren't being entered. The nurses couldn't do it. It was slowing down their rounds, all of that. So they said, well, and the nurses all thought that it was the doctors. Those lazy asses wouldn't chart fast enough, right? That wasn't the, so they looked at it and they said to the doctors, okay, why are you not charting? Well, there's nowhere for me to do it. Okay, let's look at the nursing station. This nursing station is appalling. It's a mess. There's papers everywhere. There's no space. Now, this team of people that's looking at this is nurses, doctors, IT, facilities, whoever they could get to volunteer, right? And so they asked the nurses, why is this such a mess? Well, there's nowhere to put anything. Well, what about that drawer? That drawer is broken. That drawer's been broken for months. So facilities fixes the drawer. It's like a screwdriver and a screw is the investment here. They create a process of what lives in that drawer. They open up some space. IT then says, all these CPUs that are sitting here, these computer towers, we can hang them underneath. So they do that. Now there's space. Now we designate an area for physicians to chart. Now the charting is happening on time. The bickering that was, those guys aren't doing their charting, and these nurses are too messy, I can't do my charting, ended because somebody said, why, and got the resources and group together to solve the problem. They did things like, hang places for people to grab gloves right in the room so that nurses didn't have to go running to different supply closets to get them. They put clocks in patients' rooms because patients were constantly wanting to know what time it was. They fixed a printer. Well, they didn't fix it themselves. They finally stayed on the phone and insisted they will not get off the phone until you fix this printer so that orders could come up from other parts of the hospital. They fixed something like 23 niggling problems in 3 days, and then went on to create this as an ongoing group that whenever a complaint arises on the floor, their job is to say, let's bring this to the No Excuses team and let's look at how we solve this. And the reason this is successful is this wasn't management coming in and saying, how are we going to overhaul this unit? This was the unit itself fixing their own problems. And it was a combination of that sense of agency and the solving of those problems that really resulted in the change in their culture. And so I'm going to show you a tool that is basically free, except for some investment of time to manage it, that will help you duplicate that same kind of process within your own units. And it starts on the premise of collecting information, but collecting information in the simplest way possible. So if there's a simple test of the quality of your medical care environments, it's the mother test. Would you bring your mother here for care? And so the approach that we use sort of builds on that. We call it the pulse survey. And the idea is that you take the pulse of your patients, take the pulse of your organization. How many people have done organizational surveys before? Right? They're generally huge. They happen every 2 years, maybe every year. Takes 3 months to get the information back to the organization, right? And it's so abstracted, usually it doesn't mean anything. The pulse survey is the exact opposite of that. Just as simple as putting your hand on an artery. So what the pulse survey measures is, it can look like satisfaction, but satisfaction is actually whether or not you've met people's expectations. And satisfaction is kind of an icky term, even though we talk about patient satisfaction a lot. We look at loyalty. How many people have a company or a brand that they just love? Yeah, I see some hands going up. I'll give a couple of, Apple became that for a lot of people by creating the Genius Bar. I love that we're in a Westin. Westin actually, who traveled for work sometime before about 15, 20 years ago? Anyone who would like to relive this experience, go to a budget motel, right? Because that's what it used to be like, right? You'd go through this grand hallway, the person would say, hello, Ms. Boehm, it's nice to meet you. You'd go up to your room and there'd be this like cardboard bed with a polyester bedspread, right? Westin single-handedly transformed the hotel industry because they looked out and said, you know what, one of the moments that matters is the moment when somebody sits on the bed. And they either say, ah, or they say, ew. And they created the heavenly bed. And now you can't find a hotel that caters to business travelers, that doesn't have big fluffy beds and clean white so you can see that they're clean kinds of linens, right? So it's that's what loyalty kind of gets at. Are you creating that emotional connection with people? So I'm going to skip past some of this. One of the things that we sometimes get criticized with this approach is I'm talking about surveying your local staff, not necessarily surveying your patients, although I would certainly advocate for getting both points of view. But if I had $1 to spend on market research, I would spend it on finding out what the physicians and staff in my facility think and feel. Because they have something of a pulse on what patients think and feel. And if you don't address their needs, you're not going to be able to solve the things for the patients and families. So this is some research done by Ascension Health looking at the correlation between employee loyalty and patient loyalty. And it's not the strongest correlation, but it's definitely correlated. So the questions that we use, and how many people took the survey ahead of time? There are 10 of you, and I'd like to say thank you. Okay, thank you to those 10. The questions that we ask are basically a modified version of the Net Promoter Score, and I'll walk through the Net Promoter Score in a minute. It comes from out of industry, but it's 2 questions. How likely are you to recommend this as a place to come to work? So if you had other healthcare colleagues, would you say, yes, you should come work here? And how likely are you to recommend this as a place to come for care? Those 2 questions each need to have a why or why not, or some sort of verbatim afterwards. And then there are 2 optional questions. What would you do to improve the patient and family experience, and what would you do to improve the physician and staff experience? And that's it. Those are the only questions. And this is based on a model that was created by Bain Consulting, where they did a whole bunch of research to discover that this question predicts loyalty more, and I know loyalty isn't always what you're thinking of, but that is the emotional connection, predicts loyalty better than any other question. And so you ask it on a 0 to 10-point scale. And this is also sometimes feels a little controversial. You then group people into 3 groups. The 9s and 10s are promoters. 7s and 8s are neutral. And 6 and below are detractors. Now some people say 6, that's better than half, that's above the middle, right? To Nick's point earlier, 50% of us are above average, right? But if you're going to give an organization a 6 out of 10, and somebody said to you, how likely are you to recommend your clinic? And you're at a 6, you're going to be like, it's okay. How likely are you to go to that clinic if that's the way somebody recommends it to you? Yeah, no. So the way that you calculate a Net Promoter Score is you take the percent of people who scored 9 and 10, the percent of people that score 6 and below, and you subtract the detractors from the promoters. That gives you, this also gives you a sense of, you can have some really strong advocates, and if you've got a few or a growing group of dissatisfied people, you're in trouble. And if you're only tracking your top box scores, which is what a lot of people track, you're missing this whole other dynamic that's happening on the bottom end of the scale. So this helps you capture both. And I'm going to skip through some of this. No, actually, I will walk through it. So you're going to do this exercise in a minute of actually pretending at each table that you are a clinic, take the survey as honestly as you want, and then analyze the results. And so the one person at each table will use the worksheet to calculate it. And so basically you write down all of the responses, you then group them. Those that are 9s and 10s are promoters, those that are 0 through 6 are detractors. You run the calculation, and I will walk around and help. But as important as those numeric pieces, we all like numeric pieces, right? We're scientists. We like to see how things progress over time, and that is important. But as important are the verbatims. So the fact that this survey only has 2 numeric questions means that people are usually willing to write in at least a sentence or 2. And that's where you understand why and how to fix it, or at least what the real problem is, right? Because there's a million reasons somebody could say you're terrible. So by analyzing those verbatims, you start to see certain themes emerge. Like in this case, communication these are actually real verbatims that we've had from organizations. Communication is emerging. And it's emerging on both sides of the equation, right? It's emerging in in the physician and staff experience, and it's emerging in the patient side as well. And this always happens. When we implement this with organizations, there are always people who question the results, and they should. And this is one of the reasons I'm not a big fan of benchmarking against others. I'm a much bigger fan of using those numbers to benchmark against yourselves, because any movement in that is still going to be movement of the morale within your organization. You may also find culturally there are differences. I'm going to forget, we've worked with Chinese populations and Hispanic populations, and there's one of them, I believe it's Chinese, where you do not give a 10. And so the scale has to be thought of differently. So the numeric, and that's one of the reasons why, you know, even as a quant nerd, you can't rely solely on the numbers. You have to look at those verbatims. You have to look at some of those other pieces. So it's a way of getting a sense of where you are and seeing if there is movement. So one of the nice things, or one of the things that I think is really powerful with this survey, is it is such low overhead to implement that you can do relatively frequently. The Urgent Care Center at San Francisco General Hospital is doing this on a quarterly basis. There's no way you could do a traditional employee survey on a quarterly basis. There's just too much overhead and the information comes too late. So I'm going to pick on you guys because you were talking a little bit about how, some positive things about how you might think about using the survey. Would you mind sharing some of those?
Well, it's simple, and it gives you a chance with your team. I think this is what I think with the people polls and all those 59 questions thing. You get it once a year, then you get the results 30 years after that, and it's been a moment in time that you're treating from a year ago. I don't want to know about that, but I want to know the secrets that they have that my staff has, so we can move forward and do things together well. And this is such a simple thing that even Porter was doing it and then everybody agreeing what they're going to work on. You actually work on it, you demo it in front of everybody. So that's going to be pretty satisfaction anyway. So I really like this. I've never seen it, and I think it's very useful.
So,
And where do we find it? What's it called?
well, you'll have it in the, we call it a pulse survey. We've written some blog posts on it. The questions are in the presentation, which Nick will distribute out to all of you guys. Anybody who wants it, my contact information is also in here. We've created we use SurveyMonkey, completely free. We've created a template for this. So if anybody wants us to help with setting up that template so that you don't have to recreate all the questions in SurveyMonkey, let me know. I will warn you, I'm going to look at the results if you're going to do it through us, just because I'm interested. And we've been trying to collect sort of a database of people using these questions to see how they do change over time, if there are differences between physicians and different kinds of staff and some of those other things. So happy to be a free resource for you on that. But it's also anybody who wanted to go to SurveyMonkey and do it on their own, or print out a piece of paper. I'll give you the templates for it. We also have some resources I'm happy to give away around, as I said, we try to take ideas and spread them, not charge you to do them. So I'm happy to give resources around communicating around it, because you also don't just want to throw this out there. You want to let people know why you're doing it, how their feedback is going to be used, and that's some of this. So this is the context for using a pulse survey, that you're going to be communicating why you're doing it. You're going to be administering the survey, and as I said, that can take a week to 2 weeks. You want to think about what the right unit is to look at. Really small groups can be tricky because people don't feel they're anonymous, and sometimes you can just get all those people in a room. So what's the right unit size? But sometimes a whole hospital is way too much, right? Because you can't enact change at the whole hospital level. You may want to roll it up and look at what should senior management be prioritizing overall, but any given unit might have a different set of priorities. So then the other thing is to communicate afterwards, because how many times have you taken an employee survey and then nothing changes or nothing happens? Right, so doing this, I would not recommend doing this unless you are also committed to having some people that are going to follow through on what the results are. Whether that is a no excuses team, whether that is a few senior leaders, a leadership triad that's ready to take things forward. Whether you do this before you implement something like huddles, like a best practice, to know how you need to adapt it to that environment. One time, for example, we did it wasn't the pulse survey, but we did a physician town hall with an organization in Ohio that had, it was a medical group associated with the hospital, and they were trying to do all these patient experience improvement stuff. And we did this physician town hall, and everyone, they were right in the middle of their Epic implementation. And that same curve I showed about physician, that's the EMR pit of despair as well that happens. Usually it does get better out the other side. But they were in the pit of despair for the EMR implementation. They couldn't hear anything else. So once we heard that, they had actually, the previous management had done the Epic implementation with no input from physicians whatsoever, which is asinine. Right? So they created a physician steering committee for the EMR based on that feedback and committed to creating it right in that physician town hall. And that's what gave the physicians the ability to say, okay, we're not going to solve it overnight, but I can step over that problem and start to address some of these others. Right? So it's absolutely essential to collect that voice, to feed it back, and be committed to acting on that information. I mentioned San Francisco General UCC doing it quarterly. They have stepped back from time to time. When other things come in, they sometimes say, we're going to do it 3 times a year, because if we can't act on it, we don't want to ask people, even this small amount of effort, to give us the information. So if you decide you want to take this tool or some tool like it or something, I just recommend going out and getting that pulse on your organization, whether you use this approach or some other. I would say there are a couple of other rules of thumb to look at. One is address the elephant in the room. If everybody says it was Dr. S we need to fire, right? Yes. If everybody says Dr. S needs to go, or a bunch of people do, then Dr. S needs at minimum some coaching and possibly to leave. Whatever his technical skills are, he is destroying the culture. And the culture and the environment in which you practice wonderful technical skills is a really important part to addressing this issue of burnout and fatigue, and whether your work is work or whether your work is invigorating. So that the elephant in the room might be the EMR, it might be certain staffing people, it might be the union. Bring the union to the table to talk about some of these things. It might be any number of things. But if you say there's nothing we can do about that and just ignore it, you have just held out the possibility of change and then taken it away. And that's worse than never holding it out in the first place. So I always say, address it. It may be that the answer is, we can't quite solve it, but these are at least the steps that we're taking towards it. But if you don't address it, you're sunk before you start. Second is engage staff to create or adapt solutions. And I say create, the sacred moment was created by the staff on the med-surg floor at Twin Rivers. Huddles have been tried and failed in a lot of places, tried and succeeded in a lot of places, so don't bring them to a unit without saying, okay, what's our flow? What's our rhythm? Who do we need to have? Are there people we don't need to have? What's the script? What are the questions we're going to ask in our huddle? How are we going to make sure that the huddle is time limited? Right? So how do you take a known best practice and adapt it to the culture, environment, and resources available on that unit? And it's the people on the unit that can answer that, not the managers who sit somewhere else. Third is look for solutions that address both the staff and the patient needs, right? So, for example, communication came up for everybody, and it came up both on the staff and physician side and on the patient and family experience side. So one doctor that we work with, his name is Dr. Bill Maples. He was at Mayo Clinic Jacksonville, and he is now at Mission Health System as their chief quality officer. And he looked at some of the, I'm going to get the acronym wrong, AACH? No, HCAHPS is the data. AACH is the American Academy of Communication and Healthcare, something like that. Anyway, this organization that has all these trainings around communication and healthcare. And they've got these curricula, and they take weeks to get through. And he said, I can't. So he actually worked with them and created this 4-hour intensive immersive training. And they were like, this is never going to work. But he actually managed to get it to, it works. And he's created this communication program that is geared, that addresses certain components of communication that matter both for intra-unit or intra-professional communication, as well as communication with the patients. So it's hitting both of those at the same time. And he's got an operational rhythm that has made it embedded in their culture, and they've actually seen their mortality go down. They've seen staff satisfaction go up, patient satisfaction go up, a whole bunch of improvements. We're actually doing a free webinar next week. I'd be happy to hand out the information on that. He's going to be talking about some of how he did some of these things. So if you can find solutions that address both halves of those, even better. If you have a highly dissatisfied, one of the things we saw a lot of, higher rating for place to come to care than place to come for work, right? If you take a bunch of people that are dissatisfied with their work and say this thing that they think, now they may be wrong, but they think the patient experience is pretty good and you're going to invest heavily there, and they're like, but, right? You have to address those staff satisfaction and staff experience issues as well. And then the other thing is the reason we like the Pulse survey is it allows you to continue the cycle, right? The No Excuses team didn't go away once they solved those 23 problems in 3 days. They kept going. So the value of this is to be able to have a continuous improvement model that's not so onerous, so filled with meetings, so filled with massive surveys, or so disconnected from what the real experience is on the front lines that it's not actually solving those problems. So I also brought some additional just simple templates for change management that I would encourage you, if you're interested, to pick up. I'm happy to share any of these electronically as well. As I said, we have whole huge toolkits around this. Happy to share. But I think if there's one thing you take away, is that you guys cannot be effective caregivers if you're not also taking care of each other and yourselves. So whether that is the simple mindfulness, the simple gratitude that you do for yourself, the institutional kinds of things like a code lavender or the thank you notes or other things to help you support your colleagues, or more systemic changes that you put in place to help make a healthy environment in which to promote health, you are going to be far more successful in helping your patients if you are also looking after that piece. And it's not a new concept. This quote is from 1925. So this is my contact information. Any questions, comments, feedback? Yes?
Here's one question. You're talking about ways to increase work-life satisfaction. But I didn't hear anything about employee wellness in there. Do you ever talk to people about, as we're all caregivers?
Yep.
But do you talk about employee wellness?
I have in a past life. So I used to work with a lot of insurers, and the large employers that are self-insured do a lot of employee wellness. Yeah, well, I would say mindfulness, yoga, whatever, those kinds of things are employee wellness. Employee wellness can take a whole bunch of different shapes. I think I was leaning more towards some of the mental health wellness, but yes, I mean, somebody was talking about pizza parties, and there's a part of me that cringes and said, yes, pizza's a comfort food, but it's not a healthy comfort food, right? You know, so you do have to, but sometimes a cookie's the only thing that's going to make it feel better, right? So you have to, yes, employee wellness absolutely matters, and I think it's worth investing in. I mean, there's so many studies in so many other industries that show that healthier workers can often work less time more productively, or in other ways, you know, less absenteeism, less, you know, less bickering, more willingness to listen, you know, all of those kinds of things. So yeah, wellness matters. We haven't worked specifically on broader scale wellness programs, but what we're good at is finding people who have and figuring out how to make it as easy as possible for them to do it as many times as they can. Other questions? Just for my purposes, how many people think they might try something like a pulse survey when they go back in their organizations? Okay, maybe a 1/3 conversion rate. I will consider that, for my own mindfulness and well-being, I will consider that a success. Thank you very much.